Hi everyone. The topic that we're going to cover today is really regional analgesia and anesthesia, and it's a pretty big topic. So I broke it down into four sections. We're going to start by talking about general consideration for peripheral blocks, and then some specific things to them, and then the third and fourth sections are going to be about neuraxial techniques of spinals and epidurals. So let's start with the peripheral nerve blocks. You can see some of the objectives for the first part of the lecture. So, regional anesthesia and analgesia are really any techniques that either completely numb a specific area for surgery, this is regional anesthesia, or numb a specific area enough to help with pain, this is regional analgesia. And again, anesthesia for surgery, analgesia for pain. So, if you put ice on a muscle, if you have a cramp, it's technically regional analgesia. But if you ice something hard enough to the point that you can cut the skin or do surgery, this is regional anesthesia. These regional techniques can be used alone with sedation or as part of a combination technique with general anesthesia. And often the analgesia part, the pain control part, can be extended into the post-op time. So let's say someone is having an ACL repair, anterior cruciate ligament repair. We typically do a femoral nerve block for them before surgery. So let's say this is at 8 a.m. During the surgery, patients don't really need much of any pain medicine, so they don't get much of any opioids. And the surgery is done at about, let's say, 11. Patient wakes up from anesthesia, and they don't really have much of any pain because the nerve block takes care of their pain. Alright, patient's being discharged home at about, let's say, 12:30. There is still no pain. So the nerve block that we do sometimes, usually these kind of nerve blocks last about 14 hours or so, but sometimes they can last as long as 24 hours. So they can make a big difference in patient's pain control. If we can totally avoid general anesthesia with these techniques, or even minimize the complications of general anesthesia, and specifically because of lower opioids in a combo technique, patients can definitely get benefit. They will have less respiratory and neurologic complications, to say the least. This is especially important in high-risk patients like the elderly, the obese, or those with significant respiratory issues. And especially nowadays, we have much better drugs to use in regional techniques, better equipment. We have ultrasounds available now. And these have made the regional anesthetic techniques quite easy and much safer than what they were before. All regional anesthesia is based on the exposure of nerves to local anesthetics or any other drug that makes them numb. And we place these drugs close to the relevant nerves, usually with a needle. Again, not in the nerve, but close enough to it so that the local anesthetic can diffuse into them. Some general contraindications to these regional techniques that you really need to know are patient's refusal, infection of the area, and significant coagulopathies. As you can see in this figure, the peripheral nerves have a uniform structure. As you probably remember from undergrad or courses before, the neuron is the basic functional unit responsible for the conduction of nerve impulses. Neurons are the longest cells in the body. Their cell bodies have several branching processes, the dendrites, and a single axon for the most part. Generally speaking, dendrites receive information and axons conduct outgoing information. In peripheral nerves, axons are very long. Think of a sciatic nerve going from upper thigh all the way to the foot. Each peripheral nerve can have three parts. It can have somatosensory or afferent neurons, motor or efferent neurons, and autonomic neurons. In the peripheral nerve, individual axons are covered in the connective tissue, as you can see in the figures. And the axons are covered by endoneurium. It's a delicate layer around each nerve suspended within the perineurium. Small groups of axon form a bundle called the nerve fascicle. The perineurium surrounds each fasciculus and splits with it at every branching point. Now the epineurium surrounds the entire nerve and holds it loosely to the connective tissue. In fact, if your needle is in the epineurium and inject local anesthetic, you can see the separation of the epineurium from the nerve, and if you inject with high enough pressure, you see separation of fascicles in the perineurium. If you see this, this is bad. You don't want to do this because we just injected into the nerve. The local anesthetic we injected there causes the pressure under the epineurium to go up, so it can result in ischemic injury to the nerves. We'll talk more about this in a bit. And really, as the nerves get their blood flow from the adjacent blood vessels running along their course. So if the pressure in the nerve itself is higher than the blood pressure in the blood vessels, by definition, by physics, the blood can't really get to them. The thinner the nerves are, or if they don't have any myelin sheath around them, you can imagine the local anesthetic can penetrate them more easily and diffuse through them. Think diffusion, really. Most nerves have a combination of fibers, and the thinnest nerves are blocked first and stay blocked for longer duration. Sympathetic fibers are blocked with the lowest concentration of local anesthetic, followed by pain, touch, and finally motor fibers. So you can imagine you do a nerve block, it's beginning to wear off, or it's beginning to wear off. So patients begin to move their limb, but they still have no sensation. So this is something to keep in mind in terms of watching out. When patients are under general, they're unconscious, so there's little failure rate. So you give them more drugs if they don't fall asleep. But with peripheral nerve blocks, they can always fail, so we must have a backup plan. They can fail because of improper needle placement. You were watching the ultrasound, you thought the needle tip was on the monitor, but it was past it, so you were looking at the wrong thing. You can inject not enough local anesthetic, you can make a mistake, or most of the time, we really have no idea what happened. Also, some complications like inadvertent IV injection of the local anesthetic, the last, or respiratory depression can require, urgent conversion to general anesthesia. You got to protect the airway. So, apart from the most minor procedures like, suturing a small laceration, all patients should be prepared for regional anesthesia just like the way you prepare them for general anesthesia. So they have to be NPO, and they may need medications as needed. The standard of equipment and monitoring should similarly allow for safe general anesthesia if required. So you need a blood pressure cuff, you need EKGs or the 5 leads that we use, you need pulse ox. Also, the infective complications can be really, really bad outcomes, and so we have to do full aseptic precautions like sterile field, surgical prep, gloves, and gown for when we use catheter or major nerve blocks or neuraxial techniques. This is just a simple algorithm for recognizing local anesthetic toxicity that you probably have seen before. The signs of inadvertent IV injection of or overdosing of local anesthetic, especially with lidocaine, are very characteristic. You first see tingling of the lips and tongue, then you see patient gets confused, then lightheadedness, unconsciousness, convulsions, coma, and then cardiovascular collapse. But when we see bupivacaine, this is a little different in that it's not as predictable. So patient can get confused, but cardiac arrest is usually what we see first with bupivacaine, which is not great. In the post-op period, some complications can have a delayed presentation, so we really need to watch these patients vigilantly. You can see nerve trauma or intraneural injection that manifests later because you got to wait for nerve block to wear off to see it. It can be vascular compromise if you get a hematoma there, if you injure an artery that's supplying blood to the vessel. You can have neurotoxic injected, so if you inject some solutions that are not preservative free, if you inject the wrong drug, that's neurotoxic. Infection and abscesses, usually these take a long time to develop, usually several days, but it can be as quick as a day. It can be drug related, like toxicity of local anesthetic. Patients can have anaphylaxis to local anesthetic, even though it's very rare, but it can be possible, especially with preservatives or other things in the drug. If you have adjuvants drugs that are extra things you add to the solution, or it could be the cleaning solution, lots of different things. So you gotta really watch out for them because these can be devastating complications. Now, unlike general anesthesia, when patients wake up after surgery, as you know, the effects of regional anesthesia can persist for several hours or a day. So the blocked area, if it's an arm, if it's a leg, you have to watch out for it. So, for example, if we did a brachial plexus block for somebody who was having a open reduction into arm fixation of, let's say, radius. So, surgery is done now. Patients in PACU. They have no sensation, and they can totally re-break their repair, not even know it. They don't feel it. This blocked arm is totally numb. It's heavy, and patient has no idea where the arm is unless they're looking at it. So, it can be smashed, burned, twisted, etc. You get the idea. So we have to have a plan, a nursing plan on how to protect the anesthesied limb, and also what to do at home when these guys go home with arms or legs that are completely numb. Now, a simple solution is educating the patients, their family members, and especially for upper extremity, using slings or braces for lower extremity. Sometimes we put in nerve catheters and run continuous infusion of local anesthetic for prolonged pain control. So for these, we need very regular observations to adjust the dose and rate of infusions for good pain control, and more importantly, treating side effects and rare complications like abscesses, hematomas, or that can lead to compression syndromes. This is a simplified algorithm for the early investigation and management of these rarer complications to minimize disability. So if you suspect a neurologic injury, first, just like any other thing, you go examine the patient. You do a quick history asking when, where, how, or how bad. Then you do your exam, quick neuro exam of dermatomes involved. You just touch the area, see what kind of dermatomes are in there. Temperature sensation, you just grab some ice, test for cold, and motor exam. Then based on what you find, like a neuro exam consistent with a specific nerve deficit, you have to consult the experts immediately. It can be from ischemia, from hematoma, abscess, or direct trauma from needle or injection. You need to image it immediately with MRI. Surgeons will need to evacuate any hematomas or abscesses. You need to antibiotics for infections, and after the initial problem is resolved, we need neurologists and physical therapists to work with the patient to get back function as much as possible. The main drugs that we use for peripheral nerve blocks are local anesthetics. They typically act by penetrating the nerve structure and stabilizing the nerves so they don't depolarize with the nerve impulses, and the transmission of the nerve impulses are blocked. They're grouped either into short-acting esters or the moderate and long-acting amide local anesthetics. Some example of esters, as you can see, are procaine, chloroprocaine, and tetracaine. And really, chloroprocaine is the most commonly used ester. And tetracaine, still some places use it, and procaine, nobody uses it anymore as much. Amide examples are bupivacaine, levobupivacaine, ropivacaine, and lidocaine, and we use these quite often. And in the table, you can see the maximum recommended doses for dosing, onset, duration, etc. when used in nerve blocks, epidural, or spinals. And the important thing to remember from this table is that esters, for the most part, are shorter acting than amides, no matter where you inject them. Ignore tetracaine for this. Beside local anesthetics, we tend to add other drugs to the solution that we inject. And these adjuvant agents can be vasoconstrictors like epinephrine, because epinephrine constricts the blood vessels that are around the nerve, so the local anesthetic is not going to diffuse as much into the blood vessel, and it was going to be more available to go to the nerve. Could be bicarb, because it used to prolong or improve the efficacy of the local anesthetics. Could be opioids for the same reason. Clonidine or dexamethasone, which kind of acts synergistically to improve the quality of the nerve block, essentially making it last longer and better sensory component to it.